Welcome to this comprehensive video on pediatric brain tumors for the nursing exam masterclass. This is the second most common childhood malignancy after leukemia. We will cover classification, specific nursing positioning post-op, and complications like increased intracranial pressure, or ICP. Our video roadmap includes an overview of epidemiology and etiology, classification by location and histology, specific tumors, diagnostics, management, and critical nursing care, including postoperative positioning. We will also review complications, previous year's questions, and case studies. Brain tumors are the second most common childhood cancer after leukemia. They are the #1 most common solid tumor in children. The incidence is highest between 5 to 10 years. Etiology is largely unknown, but includes genetic factors and radiation exposure. Unlike adults, most childhood tumors are infratentorial. Brain tumors are classified by location. Infratentorial tumors, 60%, are below the tentorium cerebelli, affecting the cerebellum and brainstem. Examples include medulloblastoma. Supratentorial tumors, 40%, are above the tentorium cerebelli, involving the cerebrum and hypothalamus. Examples include gliomas. Classification by histology includes astrocytoma, the most common overall, which can be low or high grade. Medulloblastoma is the most common malignant tumor. Ependymoma arises from the lining of the ventricles, and brainstem glioma is diffuse and difficult to resect. The pathophysiology of brain tumors is based on the Monroe-Kelly doctrine. Tumors cause direct compression, leading to focal deficits. They increase ICP due to the mass and edema. Tumors can also block CSF flow, causing hydrocephalus, and cause inflammation leading to edema. The classic triad of brain tumor symptoms includes a morning headache that wakes the child from sleep, projectile vomiting, often without nausea, which may relieve the headache, and papilledema, which causes visual changes. Manifestations are age-specific. Infants with open sutures show rapid head circumference increase, bulging fontanelles, irritability, poor feeding, and the setting sun sign. Children with closed sutures present with headache and vomiting, ataxia, seizures, personality changes, and a decline in school performance. What is the most common clinical sign of a brain tumor in school-aged children? Morning headache. Medulloblastoma is a highly malignant invasive tumor located in the cerebellum. Symptoms include ataxia, balance issues, and hydrocephalus. Treatment involves surgery, chemotherapy, and radiation if the child is over 3 years old. The prognosis is variable with a high risk of recurrence. Cerebellar astrocytoma is often a benign, low-grade cystic tumor in the cerebellum's lateral hemispheres. Symptoms include unilateral ataxia, falls to the side of the lesion, and nystagmus. Treatment is surgical resection, with an excellent prognosis if completely removed. Ependymoma originates from ependymal cells lining the ventricles, often in the fourth ventricle. The main issue is the obstruction of CSF flow, causing early hydrocephalus. Treatment involves surgery, which can be difficult if attached to the brainstem, and radiation. Craniopharyngioma is supratentorial, near the pituitary or hypothalamus. Symptoms include visual defects from optic chiasm compression, endocrine issues like growth failure and diabetes insipidus, and headaches. Although often benign, its location makes it dangerous. Brainstem glioma is located in the pons or medulla. Symptoms include cranial nerve palsies, such as facial weakness and swallowing issues. It is significant because vital centers for respiration and cardiac function are located here. The prognosis is very poor, as surgery is usually not possible. Diagnostic evaluation begins with a thorough history, including inquiries about morning headaches, vomiting patterns, decline in school grades, and changes in handedness. The physical exam includes measuring head circumference, a neurological assessment of gait and reflexes, and fundoscopy to check for papilledema. For diagnostic imaging, MRI is the gold standard, providing detailed soft tissue images. Sedation may be necessary for young children. CT scans are quick, used in emergencies, and better for showing calcification. Stereotactic biopsy is necessary for a definitive histological diagnosis. A lumbar puncture is used to check CSF for tumor cells, indicating metastasis. However, a lumbar puncture is strictly contraindicated if increased ICP is present due to the high risk of brain herniation. Question 1. Which is the most common malignant brain tumor found in children? The answer is medulloblastoma. Astrocytoma is the most common overall, but medulloblastoma is the most common malignant type. The treatment of choice is total resection via craniotomy. The goals are to remove the tumor mass, relieve ICP, and obtain a biopsy. Challenges arise if the tumor is in a critical location, like the brainstem. AVP shunt may be placed if hydrocephalus persists. Radiotherapy is used to shrink the tumor or treat residual cells. It is often deferred in children under 3 years old due to the high risk of severe developmental delay in the developing brain. Side effects include somnolence syndrome, hair loss, and skin burns. Chemotherapy is used as the primary treatment in young children to delay radiation. A challenge is the blood-brain barrier, which limits drug access. Methods include systemic IV administration or intrathecal delivery into the CSF via an Ommaya reservoir. Common agents are vincristine and cisplatin. Quick Q&A. Why is a lumbar puncture contraindicated when there is increased ICP? Risk of brain herniation. Preoperative nursing care involves a baseline assessment of vital signs and neurological status for postoperative comparison. Symptom management includes a quiet, dim environment for headaches and NPO status with antiemetics for vomiting. Safety measures include seizure precautions. Pre-op education includes explaining head shaving and the, quote, turban dressing, assuring the family that post-op facial edema is normal. Family support addresses fears, and age-appropriate play therapy is used for the child. Question 2. Which of the following is an early sign of increased intracranial pressure in a school-aged child? The answer is C. Morning headache and vomiting. Bradycardia and widened pulse pressure are late signs, and sunset eyes are seen in infants. For supratentorial surgery, positioning requires the head of the bed to be elevated 30 to 45 degrees to promote venous drainage and reduce ICP. The neck must be kept neutral. Avoid the operative side if a large bone flap was removed. For infratentorial surgery, keep the head of the bed flat or with very slight elevation. Position the child's side lying on the unoperated side. This prevents rapid CSF drainage and tension on sutures. Strict restriction of neck flexion is necessary to avoid compressing the brainstem. Postoperative monitoring includes neurological checks using the Glasgow Coma Scale and pupil reactions, watching for a fixed dilated pupil, which is an emergency. Monitor vital signs for Cushing's triad, which indicates herniation, and watch for hyperthermia. Check the dressing for colorless drainage, which suggests a CSF leak. The goal of fluid management is euvolemia, or slight dehydration. Fluids are often restricted to 75 to 80% maintenance to prevent cerebral edema. Strict I&O monitoring is essential, and isotonic saline is used for IV fluids to avoid the hypotonic effect of dextrose water. Pain management is crucial, as pain increases ICP. Use appropriate scales like FLACC and FACES. Medications like acetaminophen are used. Opioids are used cautiously to avoid masking changes in the level of consciousness. Maintain a quiet, dim environment. Cerebral edema often peaks 24 to 72 hours post-op. Signs include a decreasing level of consciousness and Cushing's triad. Management involves mannitol, dexamethasone, and short-term hyperventilation. Hydrocephalus can be caused by post-op edema or scar tissue blocking CSF flow. Signs are similar to increased ICP, including a bulging fontanelle in infants. Treatment involves a temporary external ventricular drain or a permanent VP shunt. When caring for an EVD, keep the drain level with the ear and do not clamp or lower it without an order. Endocrine complications are common with supratentorial tumors. Diabetes insipidus, caused by low ADH, presents with high urine output, dilute urine, and high serum sodium, treated with vasopressin. SIADH, caused by high ADH, presents with low urine output, concentrated urine, and low serum sodium, treated with fluid restriction. Question 4. A child post-craniotomy develops polyuria and high serum sodium. What condition should the nurse suspect? The answer is C. Diabetes insipidus. The nursing care plan for ineffective cerebral tissue perfusion focuses on maintaining normal ICP. Interventions include elevating the HOB 30 degrees for supratentorial tumors, avoiding neck flexion, preventing coughing or straining, and administering stool softeners. The nursing care plan for acute pain aims for a pain level less than 3/10. Interventions include maintaining a quiet, dark environment, administering analgesics like acetaminophen, and applying an ice pack to the face or head if ordered. The nursing care plan for the risk of infection addresses meningitis post-surgery. Assessment includes monitoring for fever, nuchal rigidity, and CSF leak. Interventions include sterile dressing changes, monitoring WBC count, and timely administration of antibiotics. Question 6. The hallmark clinical manifestation of a brain tumor in a school-aged child is. The answer is B. Headache upon awakening. In this case study, 6-year-old Rahul presents with recurring morning headaches, vomiting without nausea, stumbling, ataxic gait, and nystagmus. These symptoms indicate posterior fossa involvement, specifically the cerebellum, and increased ICP. Rahul's diagnosis is medulloblastoma. The plan involves surgery and chemotherapy, with radiation likely needed due to the tumor grade. Post-op nursing care includes positioning him flat on the unoperated side and monitoring his gag reflex before feeding, as the surgery was near the brainstem. In this case study, 10-year-old Anya presents with severe headaches, visual changes, short stature, and frequent urination. Her symptoms point to a supratentorial tumor near the pituitary and optic chiasm, with endocrine involvement. Anya's diagnosis is craniopharyngioma. Treatment is surgical resection. Post-op. Nursing care focuses on monitoring for diabetes insipidus, or DI, by tracking her urine output and sodium levels. We must administer vasopressin if DI occurs. This question asks about somnolence syndrome, a side effect of cranial radiation in young children. It typically occurs 6 weeks to months after therapy and is characterized by fatigue and lethargy. For discharge teaching post-brain tumor surgery, the priority instruction is B, reporting fever or neck stiffness immediately, as these are signs of meningitis or shunt infection. Long-term follow-up is critical. This includes monitoring for endocrine deficiencies, managing common cognitive issues with an IEP, rehabilitation for physical deficits, and regular MRIs for recurrent surveillance.